Right, thanks for bearing with us a little bit there, guys. I'm just going to introduce our speaker. We've got Carlita Bevege from Evidence Action. Carlita is Evidence Action's Associate Director of External Relations and works across fundraising, communications, and thought leadership. Prior to joining the team full-time in 2020, Carlita was a consultant to Evidence Action's Nairobi office, where she supported a variety of initiatives, including a global strategic plan for DeWorm the world. I'll just remind everyone that if we have time, we'll do a Q&A at the end, and you can submit your questions via the swap card app. Go into the talk, press the live discussion button, pop them in there, and have a chat at the end.
Okay, hi everyone. My name is Carlita. I'm an Associate Director in Evidence Action's External Relations team. I'm based here in Melbourne, and it's so nice to be here at EAG. I've met quite a few of Evidence Action supporters and just a lot of really like-minded people, so thank you for having me. My journey with Evidence Action began about 7 years ago when a friend sent me their website because they just knew that I would be super into it. And the more I read, the more I really wanted to be involved. At the time, I was working as a strategy and communications consultant in Nairobi, and basically I just pestered them so much that when they eventually needed a strategy and communications consultant, they could not think of me. None of you do that because I'll make sure people start doing that. So yeah, I worked with the Nairobi team for around 3.5 years, and it just felt like a really good fit. And the closer I got to Evidence Action's work, the more enamored I became with their approach. I joined the global team full-time in early 2020, and it still feels like a really good fit. I'm still just as in awe of the people who design and implement our programs as I was when I joined. And it is my privilege today to give you an inside look at all things Evidence Action. So part of the reason I started today by talking about my own journey with Evidence Action is because before I talk to you about our work, I actually want to talk to you about our values. Because aside from the fact that we're all pretty nerdy, there's actually a lot of alignment between Evidence Action's values and those of the ecologists. So Evidence Action is driven by 6 core values. First, evidence first. We never stop examining the evidence, and we go where the data takes us. This starts with the interventions we select and continues through our use of data-driven decision-making and outcomes-based monitoring. We economize without compromise. We regularly analyze the costs and benefits of our programs to make sure that we are doing as much good as possible with every dollar. We think big and we act urgently. We are unrelenting in our pursuit of results at scale. We know that poverty doesn't wait, so neither do we. We challenge convention. We are doing development differently, and we ask why and why not in equal measure. We are sincere in our skepticism and incessant in our search for solutions. Iterate again. If we can do something, we can do it better. And finally, passion throughout. We take action, converting impatience into courage. Global impact starts with asking the right questions. Why are existing strategies falling short? How can we find new solutions that are proven to work? How far can a dollar go in improving someone's health? We answer these questions by scouring the evidence for effective solutions to neglected capitals. We develop low-cost delivery models and pressure test them until we're confident in their impact, and then we scale. So what we really want to do is get the evidence on what works out of the journal articles and into the real world cost-effectively and at scale. Some of our programs are direct delivery, meaning we implement them ourselves. Others are technical assistance programs, which means we work hand in hand with governments to build their capacity to implement independently at scale. It's our birthday. It's our 10th birthday. It's our 10-year anniversary this year. only evidence action staff would celebrate our birthday with number crunching, but that's what we did, and it's actually been amazing. Over the past 10 years, we have measurably improved the lives of over 500 million. We've averted 600,000 dailies, and I love that I can use that acronym. We've supported the delivery of 1.8 billion deworming treatments, which has led to around $23 billion in productivity gains. We have averted 3 million cases of childhood diarrhea, and we've saved the lives of 15,000 children under 5, which is equivalent to 4 young lives saved every day for the last decade. I'm going to talk to you about our programs now, but first, I just want to flag that normally when I talk about evidence actions work, I have about 5 minutes to pitch one thing, and we have an hour here today, which is awesome, but I'm going to be covering a lot. So if you have questions and comments that would best lend themselves to a discussion, then let's hold those to the end. But if you have questions that are more for kind of clarification purposes, then please feel free to ask them as we go through. The other thing I'll say is that I'm a member of Evidence Action's external relations team. I don't actually work on implementing or evaluating our programs. So you will get greater breadth from me than you would from our program and MLA team members. But we do sacrifice a little bit of depth. I'm going to do my best to answer any questions that you have. But depending on how dirty we end up getting, I might have to take some personal notice. I'll be sharing my contact details at the end of the session so we can follow up. DeWorm the world probably needs no introduction in this room, but just in case, over 900 million children worldwide are at risk of intestinal worm infections. They interfere with nutrient uptake and they cause anemia, malnourishment, they impair mental and physical development. They're easily transmitted in areas that have poor sanitation, so these infections disproportionately affect people. In 2004, an RCT by Professor Ted Miguel and Nobel laureate Michael Kremer showed that deworming reduced school absenteeism by 25%. Following those same children for 20 years, they also found pretty extraordinary cumulative benefits. So decades after treatment, adults who had received 2 to 3 additional years of deworming as children reported incomes about 13% higher than those who hadn't. So finding a treatment that works isn't the challenge. It's getting a highly effective treatment to the children. And we can do this very cost effectively by delivering treatment to children where they already are, at school. So DeWorm the World helps governments provide free deworming treatment to at-risk children through a school-based delivery model. In India, we first partnered with the state government of Bihar to implement school-based deworming statewide, proving that high numbers of children could be reached cost-effectively. Soon after that, we supported the national government to launch National Deworming Day, which scaled from treating less than 30 million children in 2014 to treating over 260 million children 3 years later. Part of the secret sauce behind DeWorm the World is our unique technical assistance model. Instead of building a delivery system from scratch, which would be expensive and inefficient, we leverage existing school infrastructure and train teachers to distribute the deworming treatments. As I mentioned before, we've delivered 1.8 billion treatments across Africa and Asia, and we've done this at an average cost of less than 50 cents per treatment, and as low as 5 cents in India. We've seen worm prevalence drop significantly by up to 70, even 20% in some of the communities we've worked in. So in those places, we're actually getting ready to leave. We've actually done ourselves out of a job in some of these places, and for Evidence Action, that is a huge marker of success. So in 2019, at the Government of India's request, we actually expanded our technical assistance work to help tackle iron deficiency anemia. So anemia doesn't sound like a very scary disease. I've taken supplements for it in the past. It's the most common nutritional disorder in the world. But in low and middle income countries, iron deficiency anemia is the leading cause of disability for children aged 5 to 19. The leading cause. Evidence shows us that taking iron and folic acid or IFA supplements on a weekly basis is highly effective in combating anemia. The vitamins are inexpensive, they're safe, and they reduce the risk of anemia in children under 12 by 49%. For adolescent girls who are especially vulnerable at the onset of menstruation, it reduces the risk of anemia by 35%. By sharing operational resources with DeWorm the World, effectively piggybacking on that platform, we were able to scale IFA up quickly and cost effectively, and within 2 years, despite the pandemic, we were reaching 13 million children. Now that we've been running both programs for a while, we've actually found a way to increase the cost effectiveness even more by integrating the two programs, deworming and IFA, into a single school-based delivery platform. So the first country we want to do this in is Malawi, where more than 50% of children suffer from parasitic worm infections and anemia. We estimate that by integrating deworming and IFA, we can reduce our costs by over 12%, compared to a scenario where the programs are implemented separately. So we're now raising funds to launch this integrated program, and are hoping to kick that off next year. The technical assistance model that we built through DeWorm the World has shown to be customizable to other programs as well. An example of this is Syphilis Free Start, which helps governments screen pregnant women for syphilis and treat those who are positive. Something that shocked me when I first heard it is that maternal syphilis, so that means mother-to-child transmission of syphilis, causes more stillbirths and neonatal deaths than HIV. And part of what makes this so shocking is that syphilis is really easy to treat. Just one shot of penicillin before the 3rd trimester reduces adverse birth outcomes by 80%. So most pregnant women do receive prenatal care, and they could really easily be treated. The problem is that many of them aren't screened for syphilis in the first place. In fact, 57% of adverse birth outcomes from mother-to-child transmission of syphilis happen among women who did attend prenatal care but weren't screened for syphilis. However, due to decades of investment and effort, most pregnant women are screened for HIV. And now, thanks to a new dual test that detects both infections together, so HIV and syphilis, governments can leverage the investments they've been making in HIV to simultaneously tackle maternal syphilis. We have been working with prenatal clinics in Liberia and achieved national scale-up of this in just 2.5 years. Syphilis screening has risen from 10% to 70%, and nearly 64% of syphilis-positive pregnant women are receiving timely treatment. I might actually pause there and ask if anyone has any questions on the technical assistance stuff, because I'm going to move into our direct delivery programs a bit. With political partners? Yeah, so providing technical assistance through the government. How does that That's a good question. So I think on the technical assistance programs, one of the key things for us is that if we're working with governments, we can leverage the existing platforms that they have already got in place. So with DeWorm the World, that's an iron folic acid supplementation, that's schools. With Syphilis Free Start, that's prenatal health. And one of the things we really push for when we're working with governments is for them to take ownership of the programs. They are not evidence action programs. Once they're operating in a country, they are governance programs. And it takes time for that to kick in, but we've seen it really happen really well with deworming. So in between 2014 and 2019 in India, we watched the government expenditure on deworming go up and the philanthropic spending go down. So that by the time we were in 2019, for every philanthropic dollar that was invested in deworming, the government of India had invested $4. And so over time, the idea is that those programs become what we call institutionalized and integrated into the budgets and policies of governments. Yes. We'll move on to our other well-known program, the direct delivery program, Dispensers for Safe Water. Over 2 billion people around the world don't have access to safe drinking water. This results in over 1 million preventable deaths every year, often from diseases like typhoid, cholera, and hepatitis A. Contaminated water is also the most common reason for diarrhea, which is the second leading cause of death in children under 5 worldwide. Our network of chlorine dispensers stretches across rural communities that aren't served by a municipal water system, so they don't have pipes for them. A community member goes to their water source, usually a borehole or a well, places their bucket under the dispenser, turns the valve once to dispense the correct dose of chlorine, then fills the bucket with water as they normally do. The chlorine disinfects the water on the way home, and by the time they arrive, it's safe to drink. Many of you already know that in 2022, Evidence Action received an enormous grant from GiveWell to expand this program. And I'm thrilled to share that as of June this year, we are now reaching over 10 million people, including 10% of the population of Uganda and 15% of the population of We know that water treatment saves kids' lives, and we know it's one of the most cost-effective ways to do it. It's kind of instinctive, but quantifying that is something that researchers struggle to do for decades. But last year, a groundbreaking meta-analysis by Professor Michael Kremer and colleagues showed that water treatment reduces under 5 deaths by 25%. This means 1 in 4 under 5 deaths can be prevented just by treating drinking water. It was this study that led GiveWell to update its evaluation of safe water interventions and fund the expansion of our Dispensers for Safe Water program. And at the same time, we started looking at new interventions that we could add to our safe water. So this is a new one. It's called inline chlorination. It's a treatment solution for communal piped water sources. So a piece of PVC piping containing solid chlorine tablets, that's the blue portion in the photo, is inserted into existing piping near the entrance to a water tank. As the water passes through, it slowly erodes the tablets and the water is safe to drink on collection. So this program is fresh out of our Accelerator. We tested 6 different devices on metrics such as durability, ease of installation, consistency of dosing. Then we selected the best performing device and conducted a pilot in Western Kenya. The pilot showed a significant increase in the presence of chlorine in household drinking water. Once inline chlorination was introduced, 68% of households had sufficient chlorine to make their water safe to drink, up from a baseline of just 3%. So we're now scaling inline chlorination alongside our Dispensers for Safe Water footprint in Africa. And our next safe water frontier is India, where we are partnering with the government on one of the most ambitious safe water projects in history. It's really exciting, it's really scary. But the Indian government has committed to providing safe tap water to every single rural household by 2024. It's a huge investment, and they've made great progress. They've installed over 85 million household tap connections in the last 4 years alone. But infrastructure alone isn't enough to save lives. So as the government installs piped water across the country, we're going to work alongside them and make that water safe to drink. We have just concluded a 3-state inline chlorination pilot with remarkable results showing how well these devices work in the Indian context. And now we have a really rare opportunity to leverage the government's multi-billion-dollar water infrastructure budget. They have a $44 billion infrastructure budget. And we can incorporate water treatment through a really low marginal cost. For every $15 that the government of India spends on water infrastructure, Just one additional philanthropic dollar will make that water safe to drink. Any questions about our safe water? One thing that evidence action has learned over the years is that what we don't do is as important as what we do. In 2019, we made a difficult decision to terminate one of our programs, No Lend Season. This is actually a decision that we're really proud of. The program was designed to increase household income and food consumption by providing subsidies to poor rural farmers in Bangladesh so they could travel to cities to work during what we call the lean season, which is in between when they plant and when they harvest. It was based on multiple rounds of rigorous research, and the idea was celebrated. We received coverage in The Economist and NPR, and donors were giving us millions of dollars, and we sought to scale it up. But when we tested the program at scale, we were disappointed. There wasn't no impact, it just wasn't as big an impact as we had hoped. And ultimately, we determined that redesigning the program had too high an opportunity cost relative to other opportunities. This doesn't mean that seasonal migration subsidies don't work. It's still potentially a really great idea. But No Lend Season wasn't the best opportunity for evidence action to achieve its vision, so we shut it down. And the reason we're really proud of this decision is that it shows our commitment to going where the data takes us, to being willing to take tough decisions, and to transparency. So we were completely transparent with the public and our donors about what happened with No Lend Season. If you're going to challenge convention, you have to be willing to fail. So No Lend Season wasn't the unicorn we thought it was going to be, but we're still looking. And our Accelerator is our new program development. In 2019, we set the ambitious goal of doubling our impact by 2024 by expanding our existing new programs and by scaling up new ones. At that time, our flagships, DeWorm the World and Dispensers for Safe Water, were going strong, but we hadn't produced a new at-scale program for several years. Partly because we had a focus on nascent interventions at the time where the evidence base wasn't really well established, and so the rate that we were finding things not working was just far outstripping the rate at which we were finding stuff that was working. So we shifted to our Accelerator approach. And now we focus on programs that are what we call ready to scale, which means the evidence base is strong and the challenge relates primarily to delivery. We also have a strong focus on leveraging our existing platform skills and experience, like the examples I mentioned earlier, leveraging our deworming platform to scale up ionic acid supplementation, or leveraging our dispensers footprint to launch inline fluoridation. Our mindset within the Accelerator is to take the lens of an investor. So we only move forward with interventions that we're confident will cost effectively generate the greatest returns in health improvements, like reducing child mortality. And we're pretty ruthless about it. We regularly deprioritize interventions that don't meet our thresholds. In fact, only 2% of interventions in our Accelerator pipeline have made it through to the final stages. So I'll walk you through the Accelerator process in a minute, but maybe it's worth just talking to you about how we identify interventions in the first place. We look for high-quality studies like randomized controlled trials or meta-analyses. Our team reviews medical journal articles, WHO guidelines, and lists compiled by other organisations and experts. And we source ideas from our country teams who have really valuable insights into local needs and priorities. Ideas can come from other places as well, like external stakeholders, researchers, and sometimes even our donors. As long as they're aligned with our mission and our approach, the Accelerator team will consider them. Evidence Actions Accelerator uses a fixed-stage decision-focused process. At the end of each stage, interventions must pass a consensus decision to advance. In the early stages, when we're focused on digging into the research, we use 3 primary criteria. strength of the evidence base, cost effectiveness, and scale of impact. These criteria help us identify interventions that align well with our mission and make sure they're a good use of scarce resources. The later stages are when we really roll up our sleeves and evaluate how an intervention would work in the real world as opposed to on paper. In these stages, we make decisions based on secondary and tertiary criteria. We look at feasibility, so could evidence actions deliver this intervention in a given environment based on the resources required. We also look at fit. Should evidence action deliver this intervention? We're really primed to recognise when we're not the best organisation for the job, and we want to make sure that limited funding can be directed to those who can make the most of it. The criteria we use at the end of each stage are not stagnant. We're always iterating on them. For example, we recently recognised the cost effectiveness of leveraging our existing platforms. So we formally added a criteria about this into our evaluation framework. And through this cycle of self-reflection, we're able to increase our confidence in our ability to discern the most cost-effective, high-impact opportunities for us. Would it be helpful to go through each of these stages? Interested in that? Yeah. So stage one is screening. We start by finding interventions that are already backed by strong evidence, but that haven't progressed far beyond academic research. So they're kind of still sitting in the journal articles, gathering dust in the shelves. We examine the quality of evidence and the level of consensus that supports the impact and cost effectiveness of each intervention. From there, we move them into what we call a rapid review, where we conduct a more thorough review of the evidence to examine the intervention's efficacy, the strength of the evidence behind it, how many people are affected by the problem it addresses, so effectively the total addressable market, and its cost effectiveness. If we're still interested, it moves to the deep dive phase, which is where we actually develop the initial model of how the intervention will be implemented optimally in the real world, including where it's needed, and a detailed cost effectiveness analysis of potential at scale delivery. Then we start scoping and designing. We undertake in-country scoping to assess how the intervention can be operationalized in a specific country context. Sometimes this involves data collection, other times it means running a short-term pilot. And then only after that do we prepare for launch by making final adjustments to the design, engaging partners on the ground, and starting to raise funds for the program. Stage 5 is when we launch. It's by far the scariest. And then once we've been running a program for a while, we test it at scale. So we actually at that point start evaluating our implementation at scale to ensure that we are achieving our expected cost-effective impact. So this is the stage that Northern Season made it to, and unfortunately didn't make the cut. And then, once we're scaling something, we do continue to rigorously monitor its performance, iterating and adjusting throughout the life cycle. So what happens when an intervention doesn't advance to the next accelerator stage? Doesn't go in the bin. It's just that it doesn't meet our criteria in that moment, or we feel that there are other interventions that would be better used above bandwidth. So at that point, we what we call deprioritizing. Most interventions will be deprioritized at some point. That doesn't necessarily mean it isn't effective or beneficial. Sometimes it's just not a good fit for us at that time. So I'll give a couple of examples of what we've got in the accelerator right now. In stage 4, we're testing an intervention called multiple micronutrient supplementation, or MMS. Hey, that's the first time I've said that. Evidence shows that it can be a really effective low-cost solution if it's taken regularly during pregnancy, reducing low birth weight by 21% and stillbirths by 9%. MMS has yet to be introduced in most countries at scale. So we're looking at the feasibility of scaling it through prenatal care systems, a bit like this maternal syphilis testing and treatment. We're currently scoping that in India, Nigeria, Uganda, Malawi, and Pakistan. We're also looking at vouchers for safe water, just building on the interventions we've already got. And so in this intervention, a 12-month booklet of vouchers is distributed to pregnant women and women who have children under 5 at health facilities and prenatal care clinics. They can redeem those vouchers once a month for a point-of-use chlorine product. The product lasts 1 month and can be used to make their water at home safe to drink. So we chose this target population so we can leverage the existing prenatal care clinics to reach young children who are especially vulnerable to the dangers of unsafe. And for this intervention, we're interested in 7 countries across East, West, and Central America. An example of an intervention we deprioritized is prenatal low-dose aspirin. Research shows that a daily dose of low-dose aspirin can help pregnant women reduce the risk of preeclampsia and preterm birth. We were interested because the intervention was recommended by international regulatory bodies, including the WHO, and because aspirin is widely available at a low cost. However, as we explored the idea, we found that with this intervention, timing is everything. In order for the aspirin to be effective, it has to be started before the 16-week mark of a pregnancy. And even in countries with high antenatal care rates, 20 to 30% of the target population would not have access to care early enough to benefit. So we decided to discontinue it. Doesn't mean we won't come back to it later, but at the moment, it's just not a go. I think one of the key messages from our Accelerator team is that, again, our decisions within our Accelerator process do not mean that we don't believe in the evidence behind certain interventions. Even if the research is limited, there's always more that can be done. And many of these ideas are probably really viable programs for some organizations, maybe even evidence action for us in the future. But they're not the most promising opportunities for us in this moment. The opportunity cost of more research is really high. And so sometimes we have to be comfortable making decisions with incomplete information and exiting programs without knowing everything. Because that's what we're committed to, using evidence to scale the most cost-effective health interventions that our organization is best placed to deliver. Thank you.
Thank you, Carlita. I just checked for Carlita, there's no questions in the app, so I'll open it up if anyone's got a school raise of a hand type question. Oh, great, here we go.
Regarding Accelerator, do you share your findings from successful ideas with other accelerators?
Yeah, definitely. So a lot of it gets published on our website. So if you go to our website, the insights section is where we often publish the interventions that we've exited. But yeah, we also do have partners who leverage the research that we've done so far and sometimes take those forward.
Yeah, okay.
Yeah, I had a question about, I guess, the scaling of the Accelerator program. So, yeah, I was just curious, like, if there's any particular bottlenecks in, say, for example, exploring more and researching sort of like more ideas at the time. Like, is it just that there aren't, that many like good interventions to be, putting through the pipeline at any given time? Is it like a funding thing? Like maybe it's a constraint in the number of like researchers that wants to sort of work on these things. Yeah. So are there like any particular bottlenecks?
Funding. Yeah, there are plenty. I mean, there's certainly no shortage of interventions that we could be looking at. I think part of the challenge that we have is that funding something that might not work is not always appealing to donors. So we do accept funding for our Accelerator specifically, but often people want to donate to DeWorm or Dispensers for safe water, and so the dedicated resources that we have for research are just a bit hard to find.
Yeah, of course. Oh, yes, right.
When you deprioritize the program, is there a system in which you can communicate that to someone else, another organization sometimes you said it's not that the prevention some work that just doesn't quite fit your capability at this point in time. Is there a system in place for communication with other organisations or like outreach to make sure that it's taken on by someone else?
I wouldn't say we have a system in place to ensure that happens. Would be more on a sort of case by case ad hoc basis. But certainly if someone in the Accelerator team or someone else in Evidence Action is aware of an organisation that could take it up, we'll pass it over. And equally often other NGOs come to us and say, when did you get to? Can we pick up where you left off? And that's we're delighted with it. Yeah. The funding, we offered to return most of it. And actually, I think because we had been so transparent about it, it built a lot of trust between us and our donors. And so all of them actually just said, okay, we'll use it for something else. So a lot of it was then used for dispensers for safe water, which is where we were sort of struggling the most for funding at the time. And others went back into our Accelerator to start looking for the next big thing.
Yeah.
What's the finance matrix? So the funding is split between more established programs and the Accelerator. And what do you think would actually be a better distribution?
At the moment, the majority of our funding goes into DeWorm and Dispensers for safe water. One of the things we have just started to do is raise more flexible funds for a theme. So we have just launched a high impact school health fund and a flexible safe water fund so that people can sort of donate more to one of those concepts. Then, so if you were to donate to the high impact school health fund, that money would go to deworming and IFA and some of the new programs that we've got in our Accelerator, like HPV vaccination. Similar with safe water, if you were to donate to the flexible safe water fund, then that can go to dispensers, it can go to inline chlorination, or it might go to the artist stuff that we were talking about earlier. The Accelerator specifically, I don't have the numbers off the top of my head, but it receives a pretty small portion of our funding. It's heavily funded by GiveWell, so the really early stages of the pipeline are undertaken by team members whose positions are mostly funded by GiveWell. And then we also get retail funding through our website for Accelerator. The other thing we do for Accelerator is we use our what we call unrestricted funding. So if you donate on the Evidence Action website, one of the options is to donate where the need is greatest. And so that's funding that is really valuable to us, so we can use it wherever we need to do it. So that's it.
So yeah, so you typically channel the sort of put the money where you want funding into the Accelerator, because your view is that that's where actually there's like potential high upside.
Oh, sorry, I see what you're asking. Yes, I would say that varies day by day, really, depending on sort of our operating costs and where our donors are directing their funds. So a lot of donors specify exactly where they want their funding to go. When it's unrestricted funding, we have to constantly have this constant balancing act between the stuff that we want to do and the costs of kind of keeping the lights on, protecting against risk, and making sure that we maintain our financial health as an organisation.
Actually, you have a question as well. I'm just sort of interested in, this process when you deprioritize something, and specifically something like the Urban Season, which obviously had a lot of work behind it, and I imagine was a really difficult decision for the organisation to make. What sort of effect does that have internally, and how do you deal with that so that you're sort of able to consistently do that rather than sort of holding on to an idea?
Yeah, that's a really good question, and it is really fun. It was a really, I mean, now it's kind of celebrated as one of the best decisions we ever made, and we stand by it. But at the time, it wasn't easy. It was really hard, and it was really scary. I think the way we've staffed our Accelerator, and then the pathway into our programs is really key to that. We have team members who they start working on the research and they effectively follow the program as it moves through the pipeline, but only to about stage 4. So once the program reaches stage 4, it actually gets transitioned over to our regional teams who are already implementing programs, and then those staff members go back to stage 1. And so in that way, we're able to maintain the staffing of our teams. So that's
Yeah, I guess like, you know, is that also an attempt, I suppose, to maintain sort of emotional distance from the project itself, so that you know, you're super attached?
Yeah, I guess that's when we really go back to our values as an organisation and decide what we care about more than any specific intervention is how strong is the evidence, how cost effective is it, how big can we scale it. And so as an organisation, we really make sure that we're committed to those over and above any specific.
Yeah.
It's created noise.
Actually, I mean, it is always a figure, you know, how much you can share. I think part of it's just testament to donors that have this action, that's that they are still willing to hear that stuff and understand that we're making the best decisions we can with the information at the time. And that we will make decisions based on those values. So far, it's not. No, that has not happened.
All right, we might wrap it up there. Thank you so much, Carly. That was really fantastic.
Thank you.